Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. I am going to finish up on antiarrhythmics. I spent quite a bit of time on amiodarone, really important drug that you need to pay attention to on board exams. You do see it quite a bit in practice. Now I'm going to throw out some of the most important things of some of the other agents. But before I do that, definitely go check out reallifepharmacology.com. Simply subscribing with an email will get you access to our free study guide, 31-page PDF on the top 200 drugs. Great no-brainer to have if you're out in practice or if you're taking pharmacology exams or board exams coming up. Simply go snag that for free. Absolutely. Again, that's at reallifepharmacology.com. All right, so let's get into kind of some specific agents, and I'm really going to highlight some of the most important things that you're going to see in practice. Some of these aren't used terribly often, but I have periodically seen them tested on throughout my career on board exams and things of that nature. So, again, going to highlight the most important things here. So first off, I do want to mention Digoxin. This is classified as a cardiac glycoside. Mechanistically, it inhibits sodium-potassium ATPase. This increases intracellular calcium and has a positive inotropic effect. Okay, so it enhances vagal tone and slows AV node conduction. The two primary uses are rate control in atrial fibrillation, so that makes sense that it could be classified as an antiarrhythmic. I would probably say that's the more common indication. Historically, it was used for symptom improvement in heart failure as well. So again, that's heart failure with reduced ejection fraction, also referred to as HFrEF oftentimes. I don't see this as much anymore. We've got many other proven medications now that we typically go to, but it can be used for heart failure as well. Okay, so in atrial fibrillation, it's utilized for rate control. It is a narrow therapeutic index medication, and that's often why I see it come up on board exams and pharmacology exams. So toxicity is a concern, and we do check drug levels, as is pretty common with most narrow therapeutic index medication. All right, the biggest thing with toxicity that I have seen, or the most common thing that I have seen, is obviously I work with a lot of geriatric patients, so a specific dose that was maybe fine for a patient at age 60 is no longer fine for that patient at 85, 90. Okay, so pay attention to that, and the primary reason for that is digoxin is eliminated by the kidney. So as we age, renal function tends to decline, and that dose or that concentration within the blood can accumulate and cause toxicity. Very important thing to remember there. Another important thing is electrolyte abnormalities, specifically low potassium, can increase toxicity risk. So paying attention to the BMP with creatinine as well as potassium, very important for a patient on digoxin. All right, adverse effect profile. Let's talk toxicity a little bit. So first thing I look for is GI as well as unexplained weight loss. So nausea, vomiting, stomach upset, as well as significant weight loss. If I see a patient on digoxin and I see some of those symptoms, I'm definitely recommending to check a level to monitor that drug. As you get higher and higher concentrations, one really unique one is changes in vision, so that's definitely something to monitor. It can cause visual disturbances, and patients can sometimes report these changes in color, these yellow and green halo type things in their vision. So if you have a patient reporting any type of unique or abnormal changes in vision, Digoxin's always one to pay attention to when you're going through that med list, and make sure that those levels are assessed. And we can also cause arrhythmias and cardiac issues as we get to toxic levels, which is probably expected, right? Okay, so those are really, really big, important things to pay attention to. A couple other things, drug interactions, it does have some for sure. Verapamil, amiodarone, some of the macrolide antibiotics like clarithromycin, these can all potentially alter increased concentrations of digoxin or affect the other drugs in other ways as well. One other unique thing I have seen show up on exams is there is an antidote for digoxin toxicity. It goes by the brand name Digibind. It can actually bind up the drug if we need something acutely to reduce those digoxin levels. All right, moving on to some other agents. I'll just, probably highlight a couple of points for each one. So flecainide, this is classified as a sodium channel blocker agent, class 1C antiarrhythmic. Can be used for rhythm control in AFib, also PSVT, so that's paroxysmal supraventricular tachycardia. Avoid in patients with structural heart disease. That's an important thing to note. Also, got to pay attention to QRS widening and paying attention to EKG, which is probably pretty expected for a lot of these antiarrhythmics. Unique adverse effects. It's proarrhythmic in nature, kind of a no-brainer there. May see some dizziness as well as some visual changes as signs of toxicity and adverse effects. Next medication, propafenone, mechanistically class 1C sodium channel blocker. Does maybe have some mild beta blocking activity. This is used for rhythm control and atrial fibrillation. Again, not rate control like beta blockers and calcium channel blockers and those. It's more for rhythm control, which is not generally a first-line thing we do in atrial fibrillation, but may be acceptable in some situations. It's got the same structural heart disease warning as flecainide, CYP2D6 metabolism, so there can be some interactions there. Adverse effect profile. Uniquely, this medication can cause metallic taste. So propafenone has been associated with the taste disturbance of having that metallic taste. Dizziness, bradycardia, other possible adverse effects there. All right, then we've got a class 3 agent I want to mention, so that is sotalol. This is actually a non-selective beta blocker, or it has that activity as well as the class 3 potassium channel blocking activity. It can be used for maintenance of sinus rhythm and atrial fibrillation, ventricular arrhythmias. Important to monitor QT prolongation and pay attention to that, of course. It is eliminated by the kidney primarily, so we may have to do some dose adjustments there, and patients may be more at risk for toxicity if we go from normal renal function to poor renal function. Okay, so monitoring wise, QT interval, very, very important. Renal function, adverse effects, so torsades, got to pay attention to that, and the QT prolongation. Bradycardia, having that beta blocking type action. In addition to the potassium channel blocking action, bradycardia certainly can happen, and fatigue, which is often associated with beta blockers as well, is a somewhat common or reported adverse effect. Next medication is Dofetilide. This is guess I would call it a more pure class 3 potassium channel blocker compared to sotalol. Sotalol, it helps to remember that ending that kind of gives it away that it's got some beta blocking activity as well. But Dofetilide is more so just a potassium channel blocker, again, utilized in conversion and maintenance in atrial fibrillation. This is a medication that is actually mandatory to be initiated in the hospital in the United States. So again, you get a medication like that, obviously there's some severe potential issues with that, and certainly torsades and monitoring QT prolongation is very, very important with that. Creatinine clearance, pay attention to that. The dose may be based or may need to be changed based upon that. And then drug interactions, cimetidine, verapamil, hydrochlorothiazide. We do have a bunch with this medication, but again, typically not used very often due to that healthcare institution initiation being required. And then rate control agents, I'll just touch on them briefly. So go back and listen to those episodes, diltiazem, metoprolol. I've got individual podcasts on that. Just go to reallifepharmacology.com, hit the podcast button, and go search on the right-hand side for any drug you want. I've covered hundreds already, so go check that out if you want more details on that. A couple things I'll highlight. So diltiazem, it's a calcium channel blocker used for rate control. Pay attention to heart failure patients. We generally want to avoid in those patients, as the calcium channel blockers like diltiazem can exacerbate heart failure. So important to pay attention to that. And then kind of your classic, calcium channel blocker adverse effects, hypotension, constipation has been reported. You can get some edema for sure, as well as, you can drop that heart rate too low and cause bradycardia. Metoprolol is a beta-1 selective agent, decreases AV node conduction, utilized for rate control in atrial fibrillation. We may also have compelling indications, post-MI, for example, or maybe, migraine headaches. There's plenty of potential compelling indications for beta blockers in general. It's often the first-line agent that I see in practice for atrial fibrillation rate control. So that's definitely something to note there. Very commonly used agent, can also drop blood pressure. So pay attention to, bradycardia, hypotension, and fatigue is generally common with beta blockers as well. But again, for a more in-depth breakdown of metoprolol, drug interactions, all that good stuff, just go search up that metoprolol podcast, get the rundown, a more detailed rundown on that. All right, well, that's going to wrap up the podcast for today. Hope you enjoyed part 2 of antiarrhythmics and highlighting some of the most important things with those medications. Do me a huge favor. If you enjoyed this episode, found it helpful, leave a rating and review on iTunes or wherever you're listening. I greatly appreciate that. Support the sponsor, meded101.com/store. We've got tons of resources there, Amazon books, review courses, all sorts of good stuff on, pharmacology, pharmacy board exams, plenty of stuff for everybody, whether you're, a nurse, pharmacy technician, pharmacist, pharmacy student, and so on. So go support the sponsor, meded101.com/store. It helps me keep this podcast free and available for all to benefit from. If you got any comments, suggestions, feel free to reach out to me, mededucation101@gmail.com. I'm certainly not perfect on the podcast, so if you think you found an error or something like that, don't hesitate to reach out. I do my best to get the info right and to obviously share my real-world experience with these medications. Thanks so much for listening. Take care, and I hope you have a great rest of your day.